Hello, and welcome to Opt to Thrive, episode 27. More than just Kegels, optimizing your pelvic health and preventing leaks. With pelvic health physio extraordinaire, Andrea Picket.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Corina Sims.
Hello and welcome to Opt to Thrive. Today we have a very special guest. I've been so excited to get onto the program for quite some time, and you're going to understand why in a second. This is only the second guest I've actually had on the program, and very closely related to the first guest that I had on the program. So if you've been listening for a while, you probably would have heard me talking to Dr. Suzanne Rutherford, who's one of my besties from way back from med school. And Andrea and Suzanne also go way back, a lot longer than we go back. And so I have known of Andrea for many years. I would say 20 years or more. How long have you known Suzanne?
Yeah, Suzanne is high school, right?
Okay.
So, yeah.
There you go.
So longer than that.
Longer than I've known her. And there are lots of reasons that I really wanted to have you on the podcast today. That's going to become very apparent as we talk. But before we do, I just want to give a bit of background about Andrea so you can understand her expertise and why I brought her here today. Andrea is a highly skilled and dedicated physiotherapist with extensive postgraduate training and clinical experience in pelvic health dysfunctions for both men and women. Andrea's qualifications include a Bachelor of Science in Kinesiology with honors from Ottawa University in Ontario, Canada. And then in 2003, she earned a Bachelor of Science in Physiotherapy from Queen's University, also in Ontario, Canada. Andrea's diverse career includes working in hospitals, rehabilitation, orthopedics, but she found her true calling in pelvic health physiotherapy. And in 2014, she opened her own practice in Perth, Ontario, where she specializes in assessing and providing individualized treatment for pelvic health conditions such as bowel and bladder issues, pelvic organ prolapse, postpartum abdominal separation, prenatal care, and various forms of pelvic pain. In addition to her clinical work, Andrea is an active pelvic health educator. She regularly hosts public workshops in her community, and she has educated other health professionals through interactive pelvic health workshops, including for the Canadian Physician Moms Group and Canadian Women in Medicine Fitness Challenge and Retreat in Canmore, Alberta in 2020. Andrea also offers one-on-one in-clinic shadowing and mentorship to her healthcare colleagues. Most recently, she joined the Pelvic Health Solutions team, an evidence-based organization that educates and empowers physiotherapists, healthcare professionals, and everyday individuals on pelvic health. Andrea is also the co-founder of Birth Talks workshops for expectant mothers and the Core Plus Floor Rehabilitation Physio program designed to support new moms in their recovery. So, as you can tell from Andrea's very impressive bio, there are a lot of reasons I really wanted her to talk to us today. But beyond all of her credentials and expertise, there's another reason, and I hope that you don't mind me bringing up age, because I appreciate that you are younger than I am. But I think that, especially as a health practitioner, one of the things that I've learned throughout my many years doing this is that when I go through something, or I'm at risk of going through something, I get it a lot more than just intellectually. It becomes something that's much more real to me. And so I think that coming into this midlife period, something that may have seemed maybe a lot farther into the future seems a lot closer now to a lot of us. And I think having all of that expertise, but then also kind of coming into the midlife period, just brings a whole new level of expertise, I think. So that's another reason that I really wanted to have you here. So thank you so much for taking time to join us today, Andrea.
Thank you. Thank you for having me. This is very exciting. I've only maybe done one other podcast before, so new to me as well. Lots of presenting in the community and lots of chatting with other health professionals, and that I've done often for sure. And one-on-one every day with clients, I do feel like I spend half of my time talking and educating, and then sure, we get to some treatment or some nitty-gritty, but really it's a lot of yes, a lot of education and reassurance and support as this woman is going through a different stage of her life, right? And if it's prenatal and pregnancy, postpartum, or we've switched gears and she's like, now what's happening? And I'm into perimenopause or menopause. And that's definitely, what brought me transitioning into pelvic health work was, of course, going through two of my own pregnancies, having two kids. And at that time, really thinking, wow, this is a lot on our bodies. Why don't I know more about this? Why don't we see lots of pregnant women in this orthopedic physio clinic? Like there is stuff going on physically and a lot of recovery. And I was running a lot at that time. And I was like, how do I get back to running after a baby? Like I have no strength. How do I do that? I didn't know. No one was really right. It wasn't a normal thing to go to a physio clinic to get that kind of treatment because it wasn't an injury, right? It was just a natural pregnancy. That was lovely, right? Yeah. So that certainly is where or how I've moved into pelvic health work. Just started asking lots of questions and again, treating women of all ages. And when I would see an older woman, I'm like, okay, your back pain's been around a long time. What about your bladder and bowel issues? And they would let me know, oh, yes, that's been since childbirth. That's been since. So I definitely knew there was a big relationship and a big correlation there. Reaching out to other mentors at that time of mine who had some pelvic floor experience, they really encouraged me to say, like, go do more training in this because you truly are very interested and you want to do this. Stop sending your clients to me and go go get the
Yeah.
training and treat clients yourself. So I think certainly, being in that new stage of my life is again what brought me into pelvic floor physio. And now we're there again. Right?
Yeah.
Menopause is happening and it's like, okay, wow, this is a lot of different stuff too.
Great. That was exactly going to be my next question, was what brought you here. And that makes so much sense. So it sounds like your motivation to go into this part of physiotherapy initially was just, how do I respond to what the pregnancies are doing to my body?
Yeah.
At what point did you start to think about the long-term effects? The thing that terrifies a lot of us, more so as we age, is that risk of incontinence. Was that something that ever crossed your mind way back then?
Well, yes, I think so. Because again, as I was treating women that were maybe again older than me and were, sort of diving into their history and going, okay, your back pain, for example, maybe has been around a long time. It's not getting better, it's not getting worse, but it's just there. And then again, getting into, questioning their other bladder and bowel if there was any dysfunction. And that's kept propping up. Like every woman had something to say. Oh, yeah, I've had this. And oh, yeah, I've had that. And oh, I've been told I have a prolapse, but like, I don't know what that means. Oh, I've had a little leakage, but so did my mom. And it's fine. It's not a lot. So those kinds of things kept showing up. And I was like, okay, wait a minute. There's more going on here. What are the risk factors and how do we reduce
Yeah.
risk factors? So like, what do I tell women? What do I do? I didn't have that information. So I was asking them lots of questions, but then not really knowing what to do with it. Right. Yeah. Yeah.
So
And,
back then, when you were realizing this was something that you were interested in doing,
uh,
were there many of you around? People like you?
no,
No.
not at all. So there was, again, like in, our small area, there was one therapist in the area who at that time, she was in her middle age, in her 50s, and she would do a little bit of pelvic health work, including an internal exam. And to this day, I'd have to, I'm not even sure where she got her training for that because this is not something we get in physio school. This is after. But she, at that time, you needed a doctor's referral. So you needed to get a doctor's referral to say, I give this physiotherapist permission to do an internal pelvic health exam. So they'd have to bring that referral to her. She would do an internal exam, teach them what their Kegels were, and off they went, kind of thing. So it was really, there was a big barrier to it. Again, no one heard of it. There was no evidence to really support it. So it wasn't a thing, right? And again, after having my own kids, there was now suddenly some evidence. So like 2010, kind of a big boom of we have now level 1 grade A evidence to support pelvic floor physiotherapy as a first line treatment for stress urinary incontinence, for prolapsing, for pelvic pain. So again, as soon as that information came about, then there was evidence to support that treatment. You do not need a doctor's referral now to see a pelvic floor physio. So again, it's sort of like the docs were aware of it. Referrals are starting to make the suggestions of clients to go seek out this type of treatment. And then suddenly the physios were like, oh, we need to start doing this treatment. We need to learn how, right? So like I said, it is postgraduate work. We get a smidgen of pelvic health education in university, and then it's really afterwards. And I'm sure they're tweaking it and changing it and hopefully adding more into the program. I know they are. So that's great. But yeah, there was not a lot of us at that time. And even now, there's still not enough of us. But it's better.
Yeah. So do you find that your waiting times have blown out a bit because you're inundated with patients? Yeah.
Yeah,
A
definitely.
good thing and a bad thing, I suppose. Because
Yeah, and it does. It makes me sad because when someone works up the courage to come, right, they're finally like, oh, I'm ready to do this. And then it's like, okay, can you wait a few more months? Which
oh,
again, maybe they've had it for years, but again, someone that's pregnant, well, they can't wait. There's a bit of a timeline there. Someone that's had pelvic pain and is now ready for treatment, we want to treat as early as we can, right? We don't want them waiting. So that's hard. Yeah.
yeah. So I guess it's good as medical practitioners that we're learning that you exist and how important you are. So we're referring, but we just
Yes.
need more of you. So hopefully
right.
inspire some people today to maybe look into going down. That'd be great.
Yeah.
Okay, so as I said before, when I talk to my girlfriends, and in fact, I talked to them about talking to you today,
Yeah.
what kind of questions would you be asking? What would you want to know? Across the board at this age, the number one thing that comes up, we are all really afraid of becoming incontinent of urine in particular. And so I thought that that's probably where we could focus our discussion today. I found a statistic that said that 1 in 2 of us over the age of 70 has some form of urinary incontinence. That's huge. And you and I, that's what we see. Again, looking at some statistics, I found that stress incontinence. So forgive me, I'm going to do a very abbreviated description of stress incontinence. So when I talk to my patients, I say, when you laugh, jump, sneeze, or cough, generally,
Yes.
do you leak a bit of urine? So generally that's stress incontinence. That's the most common. And the statistics that I found were that 1 in every 5 women suffer from stress incontinence. Women who've not had a baby have a 1 in 10 chance, and 1 in 3 if you have had a baby, which we're going to talk more about because that's an interesting statistic that, coming out of medical school, what I was taught based on what we're actually saying. Urge incontinence, which is less common in younger women. I found 1 in 30 women are affected.
Yeah.
They more common as we age. And urge incontinence is when you need to go, you need to go.
Yeah.
Kind of
Not quite making it. Yes. Yeah. Definitely in line. Yeah. In general, again, speaking of Canada, like putting all of those different types of incontinence into a bubble, 1 in 3, we're saying in Canada is like at some point in your life has, and this is again for women, experienced some type of leakage, whichever one it is. 1 in 9 for men. And then another really interesting fact too, is that out of all of those numbers, 1 out of 12 actually talk to their doctor about it and seek care, right? So the numbers are really high, but yet we don't know enough to share. Maybe not everyone's asking, which is unfortunate. So the stats are really high and people are not getting the care for it, right? And then the other type of incontinence is when they're mixed, right? That I have a bit of both, right? So again, generally, my caution with women is that, if you're having a little dribble here and there, you don't think it's a big deal. It's not interfering with life. I still do everything. I'm not wearing a pad, so it's fine. My concern is that I don't want that to get worse. And it likely is going to get worse, right? So that's the thing to keep in mind. If it's there, treat early, because as the different stages of life occur, this is most likely going to get worse, not better.
Okay, that's an excellent point.
Yeah.
I think what you said is absolutely fascinating about how many women, or probably worse with men, I would imagine, are going to the doctor and talking about this. And most recently, I've had a couple of posts. My husband gets embarrassed when I say this, but a couple of posts on Facebook go viral.
Yes. Yay.
1.8 million views, which it just boggles my brain that that's even possible.
Crazy.
But fascinating that I kind of stumbled onto this in that I went down the genitourinary syndrome of menopause route.
Yes.
to a woman's vulva and vagina as she ages and goes through this hormonal change. And my goodness, it's just like I can't believe, like I've been in tears actually reading some of the comments from people, how it affects a couple, how it affects the woman, how people just don't talk to the doctor. I had one comment with these little the emoji where they're vomiting. I would never talk to my doctor about that. Wow. Yeah. So it really kind of just opened my eyes to how much awareness we need to be creating around this, and how hungry people are for learning what they can do, and maybe hopefully opening up that conversation with the doctor.
Yeah.
With
And
someone.
it's too bad when they're suffering, there hasn't been that general health awareness about their pelvic health, right? And again, in my mind, it's like, let's do it early, like teenagers in high school. You know about your parts, but beyond that, it's the health of them and the state of them. And if there is pain, discomfort, concerns, questions, who are you going to talk to? Like, you need your health provider as your person. If you can't talk to them, that's not great. Yeah, knowing what is right or wrong and really treating any young women, prenatal, postnatal. Again, I hope that they sort of forever are like, okay, I'm really now aware of my pelvic floor. And that we will go, remember, there's stages of life. Like, just make sure you're checking in and talking to someone. If things change, like, don't wait and go for that help earlier so you don't end up in menopause and really suffering in silence, really.
Yeah, absolutely.
Yeah.
Okay, so let's talk about the risk factors. I've got a list, but I'll throw that over to you and I'll see if the things that
If they match a little bit, right?
Yeah.
And again, there is sort of numerous risk factors for sure. I think for women, unfortunately, we do have maybe more risk factors than men, in the sense that just technically pregnancy is one, pressure on the pelvis, the core, the pelvic floor, that in itself. Then we layer on delivery and what type of delivery it is. And even if it's a C-section, that doesn't save your pelvic floor from trauma. Just the pregnancy itself can create that too. And then I have a core weakness that doesn't help it. And then we sort of layer on any other, again, your expertise, gynecological concerns, surgeries, traumas, pain, infections. All of those things could be risk factors. Medical procedures and medical traumas kind of thing can be risk factors for leakage. Certainly bowel dysfunction and bowel habits as well. A lot of women don't really think about their bowel movements, and just the bladder controls the concern, but really what the bowels are doing or not doing, and definitely constipation, is a big risk factor for pressure, leakage, prolapsing, that type of thing, right? So your bowel function is also just as important. Certainly other physical, mental, sexual abuse, of course, is another trauma to our system. And again, even if it's not sexual abuse, like that physical and mental trauma is stress to our nervous system. And we kind of have this understanding of like, we carry tension in our neck and shoulders and jaw, and your poor pelvic floor is going to follow suit, right? So that may change the pelvic floor muscle tension. I can have high tension. That dysfunction in the muscle can certainly set us up for the risk of leakage or urinary retention or something like that too, right? So anything that affects the muscle tone can again put us at risk for bladder dysfunction. And then, of course, we sort of quickly mentioned menopause and genitourinary syndrome of menopause. So actually, the physiological changes to the vaginal canal, the vulva, the vaginal opening, the urethra, and all of the connective tissues that surround it, leakage can occur, but so can urgency and frequency and recurrent UTIs. And again, those are things that we help treat too. So we're not just treating leakage, but it might be urgency and frequency, and I'm peeing at every hour, and right, that's a problem. So that syndrome of menopause is definitely a risk factor. So treating those tissues, dealing with the pain or changes of the connective tissues so they don't lead to those dysfunctions is important. And then really, we do have more research now to say persistent back pain in women, there's a high correlation. So I'd have to find the study to name it, but certainly there has been some information and research now to show, small studies, but showing up to 95% of women can have pelvic floor dysfunction with back pain.
Wow.
So that's having chronic low back pain can be a risk factor for leakage as well too, or dysfunction.
Okay. That's a
Mhm.
surprise to me. Yeah, I hadn't heard
Yeah.
that.
And the orthopedic clinics and regular physio clinics and chiro massage, they should be screening for bladder and bowel dysfunction and not just the disc protrusion, cauda equina type symptoms, but actually like leakage and frequency urgency. If your client is having that, please again seek out some pelvic floor help as you're doing your back rehab too.
The other one that you mentioned that was surprising to me was the mental health or the attention side of things. I hadn't actually considered that before either.
And we can't say that 100% is
Mm.
going to certainly correlate and have dysfunction, but it's definitely going to be a risk factor as far as, like I said, having any stress in the body. You might physically feel that stress in your neck and shoulders. And again, the pelvic floor tension can be there as well. And then that might, again, create headaches and technically dysfunction in the pelvic floor too.
Okay. Another thing, I have a lot of patients who are nurses, or we live in a rural setting where they work kind of for hours at a time where they can't, well, they're
Yeah.
holding on. So,
Yeah.
how much of a risk is that to the bladder?
Yes, that is also a big risk factor, right? You're really interrupting that normal reflex, that natural bladder filling, that lovely contraction after a few hours. The bladder gives you the cue to empty. It's time to listen and empty, right? Holding on is sort of dampening those signals. And then the bladder realizes, oh, okay, she doesn't want me to void when I'm full. I've got to be really full before she listens to me. And then the opposite can happen too, that women, might void often and just in case because the bathroom's there. Oh, there's a bathroom. I'm just going to go quick. You should really be listening to your bladder and letting it rule and letting it fill naturally so that, again, it also doesn't start sending you signals that it's half full and it's telling you to go all the time. That gets really hard to break, that overactive bladder syndrome.
Yes.
Right? That I'm peeing all the time and I can't help it. And it's a real feeling like I really have to
Oh,
go.
yeah.
Right?
Oh, yeah.
Like
I
we've all
know.
felt that. Yeah, we've all felt that, right?
Yeah.
So there is this, we have to break that cycle. We've got to do something different. We've got to technically bladder retrain so that you feel confident and comfortable letting that bladder fill and getting back to 2 or 3 hours of work before you empty again.
Okay. Yeah. Wow. I hadn't actually considered that either. So you're saying that when I come in the front door and my bladder says, you need to use the loo, they're just tied together. I shouldn't do that unless I really need to use the loo.
What I'll say to women is kind of just sort of check in and look at the time and go, oh, well, no, I just went at the office. Like, is it just because I walked in the door and that's my habit, right? Do I really need to go? Or no, maybe you've worked all afternoon, did not go. So then, yes, you're getting in the door and you need to go. So I usually say to women, sort of check in and decide, is this a reasonable amount of time? Is it time to empty my bladder or not, right? And then and bladder retraining is tough to do, but we sort of work with women and coach them through. We don't want you suffering, right? But how to do that with more ease. Yeah.
Yeah. Okay. All right. So I just made a little list of what would constitute normal bladder function. So people are aware of what's
Yep.
normal, what's not. I've got passing urine 4 to 6 times a day, passing urine no more than once at night, passing 1 to 2 cups of urine at a time,
Yeah.
and having a steady stream until the bladder is empty, being
Yeah.
able to delay it until it's convenient,
Mm-hmm.
and having no leakage of urine between the visits to the toilet. Would you add anything to that list?
I think that I like the frequency. One thing that I will give the women over 50, and again, you let me know if you agree, that over the age of 50, once at night would be normal and reasonable to void. Over the age of 50. So under that age, ideally we can sleep through the night. Now, again, that's not going to happen if I am pregnant in third trimester or maybe peeing all the time. So that's sort of a side note, right?
Yeah.
And that can take some retraining when everyone finally sleeps. And that can also be an issue too. If I'm not sleeping well at night, a lot of women are just like, I pee because I'm awake. And I'm like, okay, well, can we go the once? If you're waking again, we need to do something else. What can we do? We roll over and tuck back in. We ideally don't want to empty the bladder and get into that habit. And then we're waking multiple times a night to void, right? So certainly once at night over the age of 50 is reasonable for sure. It's hard to know how much urine is like that normal, and without measuring it, which we don't want to do that. Generally, I'll give women the guidelines of like, yeah, if it's a long, 5 to 7 seconds, right? It's a really long void. That's a great way to know it's good. If it was really urgent and you went to the bathroom and it was a 3-second pee, oh, wait a minute. That wasn't really worth it. That was only a 3-second little dribble something, right? That wasn't that my bladder truly wasn't full, right? So that can be sometimes a nice way to get them to understand if it's a long void.
They're over 50. Okay.
Yeah.
So, because I used to be able to sleep through the night.
Yeah.
No longer. So would you say that maybe it's possible to ignore that when you do have that wake up? Just try to ignore it and see if you can get through it? Okay.
Yeah. And I definitely will have women sort of play with that, try to ignore it. Again, like I said, can I roll over? Can I take a nice deep breath? Can I focus on something else for a second? If we've taught them, their pelvic floor awareness and connections, maybe we breathe and do a couple of contractions. And can I drift off and get to sleep? If you can't, okay, you've tried it and you're off to the bathroom you go, right? And we'll keep working on that. Generally, as their daytime voiding gets easier and as the length of time in between voids during the day gets easier and I could have more control and there's no urgency, then we should notice that the nighttime void gets easier too, or like reducing that or lengthening out that time. Like women will start to say, well, I don't get up at midnight now. Now I get up at 4 a.m. And I'm like, okay, well, that's getting closer to the morning. So something is working, right? You're on the right end of that.
Great.
Mhm.
Well, that's very promising news.
Yes.
Give that a go. Quickly, I forgot to ask about when we went back to risk factors. I have a couple of friends who've had enormous sized babies. And so
Yes.
that enormity is going to be a risk factor in itself.
Yeah, for sure. Definitely. Right. And
Yeah.
so that sort of vaginal delivery trauma, size of baby, the amount of tearing or episiotomy, how extensive was that, unfortunately, can be a risk factor. And does that actually change, right? The connective tissue, the length of the vaginal opening, the length of the perineal body because of the heaviness of baby and delivery. Again, that risk of prolapsing is there as well too. And is that again, we can have prolapsing without leakage and we can have prolapsing with leakage, right? So the connective tissue changes and laxity because of the delivery are going to affect both, the ability to stay continent. We need the connective tissues, the membranes, the fascial tissue support, and we need the muscle support, right? We need a little bit of both. And that can be frustrating for women when they might have great strength, but they have such tissue laxity and changes that they're like, my leakage is still happening. It doesn't matter how strong I get because of the tissue changes that is beyond their control from labor and delivery, right?
Wow. Okay. Right.
Yeah. I think one of the things too that we haven't mentioned that we could bring up would be just in prevention factors, thinking of like what are the jobs or what's optimal pelvic health? What does that mean? Right? Because knowing what I want to strive for, then you're able to identify if there's some dysfunctions, right? So generally, we've already talked about, yes, your pelvic health is bladder and bowel control, right? So it's control and staying continent. Your pelvic health and technically pelvic floor muscles also are part of your sexual health. So is there any pain with intercourse or difficulty with arousal, right? That's another factor of your pelvic health, right? Again, these muscles support the organs as well. They support us from feeling a heaviness or a pressure. There's a core strength, and that gets us to our exercise, right? But a core strength component that our back and our abdominal muscles, we tend to think of those as our core muscles, but we do forget or don't realize, again, the diaphragm and the pelvic floor are part of your core system, right? And so we need to put that into your workout as well. And the pelvic floor muscles also contribute to circulation within the pelvis and within the hips. a heaviness, a fullness, an achiness. We sort of think about like a menstrual cycle, a fullness and a congestion, right? Ideally, your pelvic floor muscles are muscles that can help spread circulation and drain the fluid from our lower legs and our lymphatic system. It can kind of help move and push that, right? So certainly beyond leakage, if you don't have leakage, but you're having some discomfort with intercourse, or you're having a heaviness or your pressure in your pelvic floor, like those could be warning signs of like, hey, another good reason to talk to my doctor. And ideally, again, recognizing that your pelvic health is, again, pelvic floor strength, and that function is going to help with your core strength and your lifting and your running and all of
Yeah.
the great things, right?
Yeah. All right. So before we talk a bit about how we can protect our pelvic floor and prevent problems with incontinence, maybe we should touch on mechanism of incontinence. So, Andrea, do you want to walk us through the mechanism?
Yeah. Yeah. And so ideally, the whole pelvic floor system, imagining it's the bones of the pelvis, the back, the hips, that this pelvis, its job is to transfer load and handle weight. So I am weight bearing through my legs when I'm standing, sitting, walking, moving, and I can transfer that load and absorb that load of movement and body weight throughout my day, and I don't have any leakage, right? I've got enough support and closure around my urethra that I can handle that. When that load goes beyond a certain point, again, envisioning that cough or sneeze, I still need to manage that load, but that's a pressure, an intra-abdominal pressure in my system with that cough or sneeze. And ideally, the pelvic floor muscles are strong and flexible, that they can move like an elastic band. It stays strong and taut, and it can bounce and recover. So, if we have a dysfunction in the muscle system, right, a low tone, a weakness in the muscle, technically even a high tone tension in the muscle, either way, we're not going to absorb pressures well. And when that pressure hits with the cough, the poor bladder and urethra is the opening. That pressure goes somewhere and I dribble or I drop, right? So not being able to maintain that pressure and closure around the urethra, right, is the mechanism of leakage, right? Yeah.
All right. That makes a lot of sense.
And I think that's surprising for women too, because they just automatically assume, oh, I am weak and I'm not strong enough. And I'm like, oh, okay, well, I'm not sure. Let's see that, right? So the muscles are part of it. The muscles are a component, but we can have, again, tension in the muscle system that doesn't allow the muscle to move well. And we
Yeah.
need that movement, right? Yes, we can have true weakness in the system. And again, we still can't create a closure against that pressure of the cough or sneeze. And again, if an urgency hits. So even when we have worked a 4-hour shift and we think, I really got to go, I've had my coffee and my tea and my water, and I really have to go, we should still have that closure all the way to the bathroom. And then it's timing and coordination that I can empty and let it go. So again, that's another interesting piece, that strength is one thing, and the muscle system also needs timing and coordination. And that can be very surprising for women too, right? They think, well, I've been Kegeling lots. And I'm like, okay, well, maybe that's not the problem. Maybe it is, again, this timing and coordination that the muscles need to hold on for the right amount of time until I'm literally on the toilet.
And that's part of that bladder retraining. Is
Yes.
that
Yes, exactly. Yeah.
okay? So then, if we went back to the risk factors, so we've had our babies, or we've had some maybe procedures in the area, things that now we have to live with kind of for the long term.
Right.
I mean, constipation we can manage, not holding our
Yeah.
urine. So those are kind of things, but those things that they're just in our history. We can't do anything about. We've had our babies. So then it becomes, I suppose, strengthening that pelvic floor is probably a big part of it.
Yeah. Yeah.
And
So I think then it's like, you're right. I cannot control things that have happened. I can just kind of carry forward and optimize what I can. Right. And I think that that is, again, connective tissue health, which again, in perimenopause and menopause, that's important. So am I using a vaginal moisturizer? right? Is that something that's important, which is estrogen or not estrogen, right? So the connective tissue health I can control. And then again, I can connect with a physio to figure out where and how and find these muscles. And then that's something optimally that we can work on and control. And can I then manage my way through different phases of life and try to reduce any symptoms or avoid any symptoms from happening, right?
Yeah. So you
Yeah.
had mentioned something back when we were talking about those risk factors and pregnancy and the tissue changes during pregnancy. Can you elaborate on that a little bit more?
Yeah, and I think it's more of like the tissue changes that can happen from trauma of pregnancy,
Yeah.
from episiotomy tearing,
Okay. All
how the
right.
tissues heal and recover, right? Yeah, and how that is a little bit out of our control, right? And I mean, certainly there can be tissue changes in the early postpartum phases that certainly can make that bladder control a little difficult too, just because hormonally women are also different in that postpartum phase. They're breastfeeding, right? Which is really similar to then women jumping into menopause. Their tissues are also different from all those hormonal changes that are happening.
Yeah, sorry, you had said something and I wondered if because I hadn't actually really ever considered the hormonal changes during pregnancy and how they can have long-term effects on those tissues. So I thought I'd just touch back on that. Okay, so now we're at the point where we're really thinking about our pelvic health and we want to do the best job that we can to
Yeah.
prevent incontinence specifically, as I talked about a focus today. And I guess I'm thinking a couple of things. I think in general, and then I'm also thinking in terms of, I am out here and Suzanne is out here
Yes.
trying to get women to
Work their muscles.
and work their bones and keep everything as healthy as they can. So, recently there's been a bit of debate about whether or not jumping up and down is going to be all that helpful for bones, but we know that resistance training and lifting heavy things, really building those muscles does.
That's right.
So where do you want to start?
Yeah. So I think again, my main thing is certainly teaching women. And again, if I know how I feel within my pelvic floor, you're the only one that can tell us, how's this feel? How does this movement feel? How does this exercise feel? So listen and trust your body. And if it's changing, well, then listen to that, right? So specifically, of course, with any exercise or movement, we don't want any pain. There should be, I'm working hard and huffing and puffing, but there's no pain in my back, my hips, my pelvis. So we don't want to push through painful exercises. The other thing too is even a pressure, right? If I'm lifting a heavy weight and I think, gosh, that pelvic floor is feeling like, oh, I feel like I'm falling, like that's not a lovely feeling. And that's a pressure that you're not managing well, that you seem to be feeling it and sensing it in your pelvic floor. Again, if knowing that, oh, that's not supposed to feel like that, that's not my normal, that's not a great sensation. Again, it's kind of knowing when to back up and knowing when to listen to your body. Certainly, we don't want any peeing, ideally, right? And we'll come to that too. So ideally, with any movement or exercising, we're not leaking any urine. We can handle that pressure and load that's there. And maybe more so that women in the early days postpartum, we might see abdominal separation and some abdominal, what we call like doming or pointing into the abdomen. Again, early days postpartum. So for those women, we're advising them, please don't push into that. Later in life, likely less of a concern, really. But ideally, you want to use all of the muscles efficiently. So I think thinking of like avoiding the pain, pressure, and peeing, right? If we think of those as P's, that those are things I'm watching for. And if I'm doing, let's say, a jumping jack and I'm leaking, a common thing, skipping jumping jack, right? It's like, okay, I'm peeing. Okay, I am not managing that pressure well. Okay, what can I do about that? Right? Does it mean I'm weak and I need to just do more? And that's often we think, oh, I'll just work through it and keep working harder in class. And again, that's where sometimes seeing a pelvic floor physio is going to help really decipher, well, why is this happening, right? Is it yes because you have a prolapse? Is it yes because you have high tone or low tone? Like, where do they need to be? And that's where technically doing an internal exam is a bit of a gold standard that gives us information that we can share so you can understand why that leakage is happening, right? Again, we just assume we're weak and we're just not doing enough. That's not necessarily the case, right? We see strong gymnastic women jumping and leaking, or different types of athletes, right? So it can happen to other women when the pressure is so much. So I think certainly we don't have the evidence to show that heavy weights is a risk factor for leaking. We don't have that. We don't have evidence to show heavy weights is a risk factor for prolapsing, right? So we don't need to be nervous that we're going to create this problem. If I already have a dysfunction, it may occur, right? But a healthy, happy young woman lifting weights, she's not likely going to, again, run into any issues. She doesn't have any pre-existing issues. Does that make sense?
Absolutely. So what about a healthy, happy, over 50-year-old woman?
Yeah.
So I have no problem. I don't feel any pain. I don't feel anything in my pelvic floor. I'm not leaking.
Yep.
So is it okay? I just keep going as I am, or do I need to be thinking about things like engaging my pelvic floor?
So then ideally, yes. Now there is do I need to engage it with every rep and every set? Maybe, maybe not. So that's very individual for each person, right? When we're walking, we're just walking and moving and not thinking. I'm not engaging anything specifically. I'm just trying to be tall and enjoy the walk and move. Same thing with running. When we're running, we can't inhale, exhale, engage this and do that. It's just such a dynamic, fast moving task that, the tissues are either capable of doing it or they're not. Right.
Yeah.
But I think this is, yes, where we can be specific because maybe we have had traumas of life and now my tissues and my hormones are changing. And this is when we do tend to see women might say, like, well, I was fine for the majority of my life. And now I hit menopause and now I'm leaking. Like, what did I do wrong? It's not likely they've done anything wrong. Again, it's just the hormonal changes have weakened them and their tissues, and they needed that tissue strength, and that was supporting them. So, ideally, then you're right. When I sort of get to thinking of core work and my core exercises, I love the idea of you being able to not only engage your abdomen and core, but you're like, oh, this is the perfect time to throw in that Kegel and to add in that pelvic floor connection because I am working my core and that's my pelvic floor too, right? We ideally don't want to breath hold is another big thing. That if you are doing a core movement and you're like, okay, I'm just going to hold on and do one more set, that again, your diaphragm is a core muscle. If you're bracing and holding that muscle, there's going to be pressure lower in your system. And it's going to be really hard to keep the tummy tucked in. It's going to be really hard to keep the pelvic floor lifted and on if the diaphragm is bracing down. So ideally, we should be able to go through our, let's say, bicycle crunches, and I can breathe. I'm not breath holding, right? And let's say something like a glute bridge, which is a great glute and core exercise, laying on your back, your feet are on the bed or floor, and you're lifting your hips up, right? We can think about, okay, before I lift my hips, can I set my core? So can I exhale, find my low tummy, find my pelvic floor, and then my glutes are going to lift me up. I lower down and I let them all go, right? So now you're just really maximizing that exercise as a core exercise that includes your pelvic floor, right? Because you could glute bridge 100 times and just think about your glutes and fly through it, which is great. But you could also go, oh, hey, I want to be aware of my core and my pelvic floor. I'm going to add it to that. That's the perfect time to do it, right? They're ideally, in my mind, if I'm doing a core exercise, pelvic floor is part of it, right? And so when I'm holding my plank and I'm holding my tummy in, I'm breathing during my plank. I'm not breath holding. And can my pelvic floor be there? Can I hold it for 3 or 5 seconds during my plank? When I drop down to my knees for a break, I let my pelvic floor let go. I come back up into my toes for another 10-second plank. Can my pelvic floor be part of that? You're even taking that exercise to the next level and really adding in more pelvic floor connection. That's tough though. It's tough, and there's the coordination, right? So strength is one thing and timing and coordination. So that is something that we would progress. We're not going to do that day one when we're just trying to feel and find the pelvic floor, but that long term would be a way that I don't want you doing 40 boring old Kegels in the car. I want you to put them into your workout. What do you like to do? Where's your joy with Pilates or strength training? And can you add that pelvic floor connection to that workout? With that dynamic movement, the pelvic floor is on and off, just like your abdominals are on and off, right?
Okay, so there's a couple of things I want to unpack there. So definitely we're going to get to the Kegels because obviously really important. You mentioned the breathing. I've been weightlifting for a long time, and I was taught about the breath. Definitely really important when let's say you're doing a heavy squat or a heavy deadlift. Now I'm just trying to think how I do this. So I breathe out when I am exerting. Yeah.
Perfect. Yeah. And that is definitely key. And what I will promote and share with women, even if you don't know what's going on in your pelvic floor, am I Kegling or not? Let's exhale on exertion. Okay. Exhale when it gets hard, right? And I know maybe this is going to be very different for heavyweight powerlifting. They're bracing, they're belting, they're doing different things. That's not what we're talking about. Our day-to-day movements and exercise, we don't want you holding your breath and fainting. We want you breathing throughout. And again, ideally, exhaling on that exertion is going to cue the abdominals to kick in and the pelvic floor to kick in. So you actually get more core activation with the exhale. So that's why I'm going to exhale and lift over my head, like that kind of movement, right? Yes. Yeah. So that's perfect. And women might not be doing that, or they're maybe not aware that it's very important. You know what? It might not be important if you're asymptomatic and you're pain-free and you're comfortable and you could do that easy exercise any old way. Inhale, exhale. Like that's okay too, right? Sometimes we, as health professionals or fitness professionals, we drive people crazy with the technique and the skill and the breath and inhale and exhale, and women get really frustrated with that, right? So sometimes we need to just slow it down and make it easier and be like, okay, let's just focus on the exhale when you're lifting that weight. And does that immediately change something? Is there less pressure? Is there less peeing? Okay, you did it right. Your body likes that. That was a good technique for you. It changed your symptoms. So that's perfect for you, right? And I think that's, a key thing. Letting the client decide, does that feel better? There's less symptoms, then I guess I'm doing it right. That's the right way for my body. That feels better, right?
Yeah.
Yeah.
But am I at risk if I'm lifting heavily? I'm fine, but I choose not to pay attention to the breathing. Am I at risk?
So no, we're not going to say lifting heavy is going to create leakage or create a prolapse. If I have an existing prolapse and if I already have leakage, lifting heavy in your best interest, well, maybe not. Right. So that's where that risk factor can come up if I have pre-existing things that are symptomatic. Ideally, I'm aware if I have a significant prolapse that's been diagnosed and I'm aware of that. I still want you to exercise with that prolapse, but I don't want you to be symptomatic with it, right? I don't want you lifting heavy and feeling pressure. No, thanks. That's not a nice feeling, right? So, some women may have to modify, but if you are status quo, then you keep going, you listen to your body, there's no new symptoms, we keep going and see what you can do. Yeah.
Because I have heard someone say something about, lunges are terrible for women in their pelvic floor. No, we can say
not at all. Love lunges, love squats. I love all the things. And I do think variety is nice, right? That, I know you're doing lots too. You're walking, swimming, biking, and lifting heavy weights, right? And I think that sometimes is where if someone is doing one thing, then I might, just for the sake of, we want the pelvic floor and all of the muscle system to be dynamic, right? We need strength, we need endurance, we need power, and we might need to get that with different exercises too, right? So I might need some endurance of my pelvic floor and some walking. I can add in some power that I can bridge and lift and hold. That different types of exercise are really nice too. Mm-hmm.
Okay, so let's get on to the Kegels now.
Yes.
So I read a startling statistic that 1 in 2 of us are unable to contract our pelvic floor correctly. So I guess I want to know, how do we know we're doing it correctly? How often should we be doing it?
Yep.
Okay, let's start with that.
Okay. And so again, easy gold standards. I'm going to see a physio and they're going to help me determine if I'm doing it correctly. Okay. That's the obvious answer. But at home on your own, you're right. Like We think of Kegeling as trying to stop your flow of pee, right? And that's one sort of visual cue you can give yourself. Like it's the muscles that surround the area that I don't want to pee, and I'm trying to squeeze those muscles. But it also goes beyond that. It's the vaginal opening, and I'm trying to pull in a tampon. Like that's the pelvic floor. Rectally at the back, the rectum is also the pelvic floor. So I'm trying to stop the flow of gas. That's also the pelvic floor at the back. And ideally, we can feel all areas. I can separate them a little bit and they can be a team together, which is interesting too, right? So you're right. It's difficult because these muscles we can't really see and feel easily to identify with and know if I'm doing it right. Certainly, you can, simply place a hand on the perineum, place a hand right on your pelvic floor. And when you try to stop your fee or squeeze, do we feel any movement of that tissue? So I can simply put my hand there. Do I feel any movement? You can literally grab a mirror and have a peek. And do I see that center perineal body? So between vaginal and rectal, is there any movement of that? So do I see the vaginal close, the opening close? Do I see that center perineal body lift a little bit? Do I see the rectum wink a little bit? That's pelvic floor movement, right? So that can be another way to identify. Certainly, you can simply, a clean hand technique. I can insert one digit myself and kind of go, hey, do I feel a closure? Do I feel a sensation around my own digit internally? That's another way to kind of identify where these muscles are. A lot of women might try to stop their flow when they're on the toilet and they try to practice there and they say, oh, I can do it or I can't stop it. Ideally, we don't want you to do that on the toilet because we want you to just pee and void and empty that lovely bladder and do not disrupt that task, right? It's okay when I'm voiding and I'm done my pee or when I'm done my bowel movement, you could sit there and kind of appreciate, okay, I felt that void. Right? I felt that release occur. Now that I'm done, can I stop my pee? Can I move that tissue myself? Can I move the rectum? Can I move the vaginal opening? Can I identify any activation myself?
Wow, that's such great information.
Right?
First of all, I am just going to raise my hand. I am very guilty. I made it up myself, but I told people, well, just try to stop yourself from weeing when you're on the loo, and those are the muscles. So I'm going to stop telling people that.
Well, and it really is like the best way for people to get it and understand it. Right? It's like the action of sitting there and you need to stop your pee quick. Those are the muscles that do it. So again, I'll say to women, don't worry. You've done it once in a while. That's not creating a major dysfunction. But as a daily habit and as a way to strengthen your pelvic floor, we're just not going to do it on the toilet. You do it not once in a while just to see, again, isn't going to create an issue, right? But ideally thinking of like pelvic floor muscle training, we're not going to sit and interrupt your flow of pee. And yeah.
Okay, so how often should we be doing these Kegel exercises?
Yeah. Okay. And just like anything else and any other woman, it sort of depends where you're starting at, right? So again, happy, healthy woman without any issues, your strength training maybe 2 or 3 times a week. I want your pelvic floor strength training 2 or 3 times a week, right? So certainly if there is dysfunction, then that's when the frequency might be, okay, we're just trying to create some awareness and some connection and some coordination. So we might have to do that every day, right? Because coordination and awareness takes a lot of time. So again, after baby, after surgery, after trauma, right? When I'm just trying to like rehab and connect and figure this out, that's when we might be saying to women, okay, you might have to go home and do this, once a day, twice a day, until we get you to a point that you're not symptomatic, your pelvic floor is happy. Then ideally those pelvic floor connections are part of your strengthening a few times a week, right? That I don't have to Kegel 1,000 times a day to maintain it. I have a good connection. I've got a good awareness, but I think about that with my strength training a couple times a week.
Okay.
Right? Does that make sense? So again, oftentimes, right? And people want that. People want numbers. Give me the reps.
Yes.
Give me the sets.
Yeah,
How many
yeah.
should I do? And I struggle with that because again, it's very individual, right? The 3 sets of 10 for strength training, when again, you're happy and healthy and no issues, then sure, you can do that 3 sets of 10 for your squats, right? And progress on that. It depends where you're starting at with your pelvic floor. If your endurance and your awareness is only 5 repetitions, then okay, we start with 5 repetitions and you're going to do that twice a day, right? Ideally, I like to also introduce that connection and that awareness in different positions and different postures. So not just lying down, but I want you to have that 5 reps of awareness. Can you feel that in sitting? Can you sense that and feel that there? Can you do that in standing, right? So the repetitions maybe didn't increase, but the different positions maybe changed, right? Once they can do it in lots of different positions and they can do more reps, then okay, can we get through 10 repetitions? Again, when we're starting to just like, I've got this, I can feel it, I can do it. 10 reps is easy. Okay, let's do it with movement. Let's add it to movement. Let's make it functional so that you've got it forever and it's part of your workout and it's part of that routine, right? That I don't have to do these, again, boring physio Kegel exercises over here, that I really have this habit and awareness and I keep that connection going throughout my life kind of thing.
So just like any kind of, I guess, muscle training, once
Yeah.
I'm pretty happy, I can do it a couple times a week and I can maintain those effects. Is that?
Exactly. Yeah. Right. Again, that sort of, if you don't use it, you lose it. Sure.
Mhm.
That happens. And I think that's partly the case why we're not aware of our pelvic floor because, it maybe has gone through a lot and no one's ever really taught me. I've never been aware of those muscles. So it's not something I think about. Right. And ideally now sort of making this connection and making this awareness, again, does it give you more strength? And again, even when you're not symptomatic, do we want you Kegeling? Technically, yes. I want you core strengthening. That includes your pelvic floor exercises, right? We want that for walking power, for balance, for fall prevention, for all these amazing things as we age, right? We need your core strength and we need that ability. So ideally, Kegel exercises are just part of that regular activity that you're doing.
Awesome. Love
Yeah.
that. Anything else you wanted to say about the Kegels before I?
Yeah, good question. So, yeah, I think definitely like the progression of different postures, different positions, moving into dynamic movement is a nice way to progress your pelvic floor versus it just being, oh, yeah, I can move that muscle and just Kegel sitting here. Okay, well, can you coordinate it with your movement? Can you coordinate it with your exercise? Can you add it to your gym routine? Is again taking that core strength to another level, right?
Yeah, that's not something I had ever even considered before.
Yeah.
I know I've had different people and probably heard different places people when they brush their teeth or when they are driving in the car or that's
That's
when
right.
they do their Kegel exercises.
I don't want to ever discount someone from doing something that they're like, I'm really trying, right? And I'm doing it in the car and I do them here and there. And I'm like, that's great. You know what? I'm happy that you're thinking about your pelvic floor and you're aware of it. And if you can sense it and feel it, well, you're doing something right. So that's, one technique. And then I will sort of encourage them, but what is your goal? Like if you want to lift heavier or you want to run, you want to do dynamic things, then we need to make those Kegels dynamic. We need to learn how to coordinate them with other movements so that that's the goal you want to achieve. So those quick little ones when you're in the bathroom are not going to get you there. They're still good. They're still good because it's keeping the connection and the awareness alive when we want that, because 1 in 2 women can't, right? So you've maintained that connection, but now we need to progress that strength in a different way.
I think that you're in a really unique position to see some things that I'm very interested in. For instance, one of the things that we talk a lot about after this kind of stage of life, around this stage of life, midlife, and the hormonal changes is using vaginal estrogen as one of those things. I'd love to hear your take on that because you would see people who come in that they haven't been using it, then they start using it, and then you're working with them. So can you elaborate more on your experience?
Yeah, definitely. And we will see, yes, women of all ages, of all stages, with vaginal moisturizer and or without. As physiotherapists, we do not prescribe medication, but basically, I can certainly share and with them, give them more information about themselves and any tenderness to light touch, any tissue changes and color changes of the tissue and, narrowing of that vaginal opening. So any little signs that we're seeing of tissue changes, like I'm sharing that with the clients and then letting them know, hey, it would be lovely, to chat with your family doctor. You may consider technically an off-the-shelf vaginal moisturizer or a prescribed vaginal moisturizer. And I do think like a lot of women are unsure of like, well, why would I do that? Because I think I have enough moisture, I'm fine kind of thing. But really, it's to help with that elasticity and that tone of the connective tissues, right? Your muscles can be part of that and get some blood flow and circulation to them, but we need the tissue health, right? And certainly if there's pain with light touch, if there's pain with intercourse, those are concerns that we're not going to Kegel and strengthen when you have pain. We need to deal with the pain. And then when the muscles are happy and healthy and the tissues in the surrounding area are happy and healthy, then we can progress with Kegeling and strengthening, right? Again, a lot of women come in thinking, oh gosh, I need to get going and I'm just not moving or doing enough. And oftentimes I'll say, hey, you're having some tissue issues. Those should be addressed, right? Not technically my job, but hey, let's go back and chat with your family doctor about what would we do about that and what are the benefits, right? And that they will, off the shelf vaginal moisturizers that have hyaluronic acid and vitamin E or your estrogen based vaginal moisturizers, they're very comparable, I think, right? You let me know, but I see very comparable results that women come back and after 6 weeks of use, they're like, yes, there we go. Those tissues are happier. Okay, so now can we move in and around those tissues and can we create some control? And again, create that muscle awareness. Really hard to feel and find a muscle if it's painful in that area, right? It's just
Yeah.
not going to happen.
Yeah. And something shuts off, I think, too, when you try to
Yes.
work a muscle that's in pain, doesn't it?
That's right. Yeah. And often women, we just want to like, ooh, forget about that area and just sort of like, ooh, I just try to ignore the pain and get through the day. But then I'm ignoring everything, the muscles and the awareness and the sensations, right? So I would say that is definitely a huge factor. And with perimenopausal and menopausal women, that I'm, really educating them on the tissue health is just as important as the muscle function, right?
Yeah.
And we need that. We need both for continence, right?
So you mentioned a couple, so hyaluronic acid, vitamin E, and there was another ingredient that.
Just that was sort of the main active ingredients in the off-the-shelf vaginal moisturizer versus your prescription, maybe more of an estrogen-based vaginal moisturizer.
Yeah. So I guess my experience would be more along the lines of the estrogen base.
Yeah.
And so the vaginal moisturizers, it sounds to me like you're seeing that they're quite effective. And so when you're recommending a vaginal moisturizer, those are the kind of ingredients you're looking for. Is that right?
Yes, definitely. Yeah. Versus, other women might apply other things, whereas those ingredients are going to have similar rejuvenating factors like the estrogen is having, trying to plump up and rejuvenate and bring some health back to that tissue. And that's what it's trying to do. And often if women have been using one and they think, oh, it's good, but I'm a bit better, but not good enough, then I'll say, okay, yeah, please discuss that with your doctor. Maybe they will switch you to an estrogen one then, right? Or if I've been using one estrogen one for quite some time and I'm kind of plateauing or stalling out or things are changed, okay, chat with them again about do I have a new dose? Do I try a different prescription? Do I do something different? Because we continue to change and the tissues continue to change, right? Menopause just keeps going on. It's not like a one and done. Right? All of the tissues continue to change through life. So we might need to change up what you're doing. It works for a year or two, and then, oh, hey, things are different again. Okay, maybe we try something else.
So as your experience, I would imagine you would have seen in your years in this field, the experience with vaginal estrogen, you would have been seeing it more and more, I suppose, as the years have gone.
Yes. Yeah, definitely more use, less concern and less hesitation. And, women are more acceptable to using that and recognizing it's topical and it's just locally trying to treat those tissues to make them happy, right? Not a systemic effect, right?
Yeah, very minimal absorption systemically. That's one of the things that I've seen on these posts, women terrified that they can't use it because they've had different cancers. And I know there was a paper. So we are very fortunate to, in our little regional community, have a pelvic health physio. And she's just brought on a trainee in the last couple of years.
Yay!
Now time seems to fly. So yeah, I have never, ever had access to a pelvic health physio for my patients. So that has been a real amazing game changer. She sent me a paper last year and I looked for it. I couldn't find it. I think it was last year or the year before that talked about vaginal estrogen and the safety behind it. So it's a new paper and it talked about, in particular, we've always been very cautious about prescribing vaginal estrogen for women who've had a history of breast cancer. And the paper in particular addressed that and said that for even most of these women, it is safe. And so I just wanted to throw that out there. For my patients, I will generally contact their specialist, or if they have an appointment coming up, I'll say, look, I think it's probably safe, but have this discussion and we can get the okay and we go from there. So I just wanted to throw that out there.
Yeah, 100%. Yeah, that's right. And I've definitely seen women with that type of history and with the approval of oncology or specialist, and they're happy to take it too. Yeah.
And here in Australia, similar, I think, to you can just refer yourself to physio. You don't need a doctoral.
Yeah. Yeah, it's great. So yes, and for physio in general and pelvic floor physio in Ontario, in Canada, you don't need a doctor's referral, so they can just come, so we're often then, giving the clients lots of education about themselves, letting them know, please, by all means, discuss this with your doc, bring them into the conversation, or, hey, do you want me to write them a note so they have some information? And it's hard to explain this stuff sometimes, but I'm happy to send them a note to let them know, this is what you're feeling, this is what I'm seeing, what would you recommend to help out, right? So there's a lot of great communication, which is nice. And the clients feel supported with that, which is great, right?
I do. Yes, she does email me occasionally and say, look, I've seen so-and-so with patient consent. And I think that she would be an ideal candidate for vaginal estrogen or, that kind of thing. So we communicate back and forth, which is just brilliant.
I would say, of course, the only barrier to technically physio and pelvic health physio is, often the majority of this is a private service and a privately paid service, right? So, that is too bad. And, we're sort of seeing glimmers of like, this could potentially change. But it is a private service that if you don't have work benefits or coverage, seeking out this type of care can be difficult.
Absolutely. Yeah, that's one of the things that we're seeing here. We do have some patients, I'll just throw this out there for the patients in Australia who are under chronic disease management plans, and then that allows them some kind of Medicare rebate to allied health. And so they can access that.
Yeah, we do have that as well, that we do have some on Ontario OHIP covered services for a certain group of people. Again, still tricky to find physiotherapy within those services. There's just not enough of this and not enough in the right locations and whatnot, right? Yeah.
Okay, so I think I've probably taken up enough of your time, but I think you have mentioned, more than just incontinence. That's just where I was focusing today, pelvic health, more than incontinence. I don't know if you wanted to talk a little bit more about that. Do so if you want to. I just really also wanted to get your top tips, take homes for what they can be doing to protect their pelvic floor and when they should be seeing someone like you.
Yeah, exactly. Right. And I think that, again, certainly thinking of, seeing a pelvic floor physio, technically anytime you want, right? You just want to learn more and know more. And exactly this conversation, like, give me the nitty gritty, give me your tips, give me my do's and my don'ts, right? Like, certainly consulting someone one-on-one, I'm saying very general things, but ideally that individualized assessment is, of course, more meaningful, right? For sure. Again, thinking of, different stages of life. And generally, if I'm having symptoms, right, and the functions of your pelvic floor, if I know what the functions are, if there's any symptoms that are related, it's time to seek help, right? So again, that bladder and bowel control, certainly core strength, core dysfunction. Again, any pain or discomfort in the pelvic floor area, vaginal, rectal, and those certainly are reasons to consult your health provider and or find a pelvic floor physio. Specifically the bladder habits and toileting, again, knowing what the norms are, right? I'm going to avoid that. You said 4 to 6, I say like even 5 to 7 times a day. So my normal voiding pattern in my waking hours, that is 5 to 7 times during the day. I'm not going at night unless I'm over 50 and once a night, right? So again, knowing those norms. And if I'm outside of that, then that's a dysfunction that, hey, let's check in with someone, right? Listening to your body when you're exercising, right? Listening to this is pain-free and comfortable. I don't have strange pressure. I don't have pain. I don't have that. Even the sensation of like, ooh, I might leak. right? We don't like that either, right? So I want you to feel confident, right? So a lot of women are like, well, I don't leak when I exercise, but I feel like I might, so I better stop. And they're listening, which is a good thing. You're listening to your body, and watching for any signs and symptoms is really important for prevention, right? A couple of other things too. I like the idea of maintaining that fluid intake, your water intake during the day. And certainly toileting habits and bladder habits might change a woman's opinion of what they can drink and how often they can drink. But ideally, with a happy, healthy pelvic floor, I can get I'm going to generally say, I'm going to get my 2 liters in a day, and I still have control and I still am continent, right? So a lot of women will deprive themselves of water just to try to gain some sense of control. So being able to maintain that water intake is great. When you are voiding and toileting, so again, some toileting habits, that I'm going to sit on the toilet to pee. I'm going to sit down and relax and let go. So we want to avoid that hovering on the toilet, right? We want the muscles to relax and let go. That's their job, and we don't want to interfere with that. We want the bladder to fully empty. We want the nervous system to fully relax and let go. So sitting down on that public toilet ideally is recommended. And then also with toileting for your bowels, I love a footstool. So 2 feet up on a footstool is just a nice way to give the pelvic floor a lovely stretch, right? And that you're keeping all of that pressure rectally. That rectal angle actually changes when the knees come up. So it's an easier way to empty, and it's going to maintain this lovely bowel routine and helps to avoid any constipation just by having the feet up. So those are a couple of nice toileting habits that I really like too. We did also say with exercise too, with certainly avoiding breath holding, right? The exhale on exertion, right, is another great one. I think too, another important thing is certainly, we're talking about strengthening exercise, but just general mobility, right? So general mobility within the spine and general mobility within the hips is really important to keep the pelvis and pelvic floor happy too. The hips and the deep hip rotators are best friends, and they're neighbors to the pelvic floor. Being aware of, again, I have some hip stiffness, I have some hip tightness with my warm up or my cool down. That's maybe something I want to look into more and address so that it doesn't create more pressure in my pelvic floor, right? Also not something we think about.
Oh,
Yeah,
wow.
right?
Crossed my mind.
Yeah, that's right. Yeah, so anyone that's struggling to absorb pressures will definitely be screening their back and screening their hips, and maybe giving them a mobility sequence for their back and hips to create some softness and reduce the stiffness and pressure in the area. So again, they can squat deeper and absorb that pressure with more ease, right? Yeah, so sort of that hip mobility and the mechanics we want to peek at as well. And that might be contributing to the pelvic floor dysfunction. They don't necessarily need to Kegel. Okay, you've got your Kegel. That looks pretty good. You can do it well. You can activate it. It's actually this hip stiffness or tightness that might be the issue too.
Okay. Wow. I never would have thought of that.
I know, right? Yeah.
I love the footstool.
Yes.
I'm going to get a footstool. I have seen them in people's loos, and they don't have children, and I have wondered, but now I know.
That's why. Yeah, you're right. Everyone, men, women, children. It's a great, yes.
Good time to talk about making sure that you're getting plenty of fiber to keep those bowels working and lots of fluid, as you talked about as well, making sure you're not backing up on your fluid to keep your bowels moving regularly and soft and not straining.
Yeah. Yeah. And that again may be something that if someone's coming in with leakage as their main concern, and they think, oh, well, that's just been my bowels. They've always been like that. That's my normal. And I'm like, okay, well, now let's do something about it, because that long term isn't great for your gut health and your digestive system. But in general, it can be a contributing factor. So let's get this under control. And what happens to your leakage? Are you good now? Or do we continue on with that too? Right? Yeah. Not recognizing that pressure, heaviness can affect the muscles and the bladder control as well too.
And that's another one that our pelvic health physio has talked to me about. I think this patient needs something for their bowels, or I've seen patients come in where she's recommended something for their bowels. And I hadn't actually really, as the GP, I hadn't actually even considered that before. So another really good message.
Yeah. Yeah. And again, I think that when we kind of go back to that general health of the pelvic floor, bladder and bowel function, right? they're both there. If there's a problem in one, it might snowball into a problem of the other areas too, right? Yeah.
All right. Well, I think that I have kept you long enough, and it's probably time for you to get home because it's
No,
a day for you.
that's okay.
There's so much good information here. I
Yeah.
am just so thankful that you took the time out to join me today. This is going to help so many women, I'm sure. And if nothing else, to be more aware that there is help, that this is treatable. So see your doctor, check in with the pelvic health physio.
Yeah. Yeah. Ideally, yeah, that's exactly it. Right. And I think that, that's the thought of like, I don't think I have any dysfunction. Well, that's great. Let's keep it that way. Right.
Yeah.
Let's just, we meet once or twice and just here's all of the things. And yeah. And again, what to be aware of and watch for, because again, we keep referring back to the stages of life. And as we change, that we might need to seek out some care with someone at different times for sure. Yeah.
So, Andrea, if someone wants to see you, to book an appointment and get an assessment and talk about all these things, where can they find you?
Yep. So my business is my name. It's Andrea Picket Physiotherapy. We do have other pelvic health associates that work here with me, and we are in Perth, Ontario, Canada. And certainly we do clearly one-on-one individual assessments and treatments. And if you're in Ontario, technically we can do telehealth visits online. So I will do that within Ontario. Yes.
Awesome. Okay. All right.
Thank you for having me.
Have a
Okay,
good
have a good night.
Okay. See ya.
I hope that you have enjoyed today's episode of Opt to Thrive. And if you have, and you can think of someone else who might benefit from this information, please pass it along. And do me a favor, if you haven't yet taken a second out to do a rate or a review, I would really appreciate it if you did that before you signed up today. I hope you have a great week, everyone. And until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts her medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.